I'm Amanda Oakley. I'm a dermatologist from Hamilton. I'm here to talk to you about the assessment and monitoring of psoriasis. Psoriasis is a chronic skin disease with well-circumscribed, scaly plaques with a roughly symmetrical distribution. It's a skin and a nail disease, associated with other autoimmune diseases, and associated with metabolic syndrome in the severe cases. Psoriasis is influenced by drugs such as lithium and lifestyle choices, particularly alcohol and smoking. When we assess a patient with psoriasis, first of all, we need to classify what type it is. We may decide to classify it by age. Early onset is less than 40 years of age, and late onset is more than 40 years of age. Acute or chronic, localized or generalized, small or large plaque, or pustular. Acute psoriasis is uncommon, and most patients will be referred to a dermatologist. Guttate psoriasis is post-streptococcal, exanthematic psoriasis, erythrodermic psoriasis, generalized pustular psoriasis, and unstable plaque psoriasis. Everyone else has chronic plaque psoriasis. It can be localized to the scalp, to the elbows and knees, to the flexures, to the palms and soles, or just affect nails alone. Otherwise, it's generalized. So small plaques are less than 3 centimeters, and large ones are greater than 3 centimeters. So a patient may be classified, for example, as having early onset, generalized, chronic, large plaque psoriasis with nail dystrophy. We need to assess the extent and severity of the disease by examining the whole body, the head and neck, upper limbs, trunk, lower limbs, and nails, and record the result. There are several ways to record the result: PASI, PGA, PSA. The main one we use is the PASI score, Psoriasis Area and Severity Index. It's a very complicated scale, rating the extent of psoriasis in each of 4 body regions: head, upper limbs, trunk, and lower limbs. It also rates the severity of the plaques in those regions as to how red they are, how thick they are, how scaly they are, on a score of 0 to 4, and then you have to add and multiply. Well, to make it easy, I suggest you use an online tool that does the hard work for you, or download one of the several mobile apps to your smartphone, and you'll find it's not so hard after all. We expect our patients to be assessed for their cardiovascular risk factors and diabetes. So that means measuring height, weight, and waist circumference, taking a blood pressure, and routine blood tests may include glycosylated hemoglobin, lipids, blood count, liver and renal function. Many patients with psoriasis, particularly severe psoriasis, also have inflammatory arthritis. PASE, PEST, and some other systems are used to determine the severity of symptoms and whether a patient ought to be referred to a rheumatologist for further assessment and treatment. Most importantly, how does the psoriasis affect the patient? The Dermatology Life Quality Index is a series of 10 questions that assess this. If the patient has a score of 0, they're not bothered by their psoriasis at all. If they have a score of 30, that's the maximum score. Generally, the DLQI and the PASI match. So a PASI of 12, a DLQI of 12 is what you'd expect. So now let's think about monitoring patients who are on treatment for psoriasis. We may need to reassess the PASI score and the DLQI from time to see if we're on the right track. In a patient with mild psoriasis, which here we're defining as having a PASI less than 10 and a DLQI of less than 10, that is to say, it's not very extensive or severe, and it isn't bothering the patient a great deal, we'll be treating them with topical agents, and review can be on an as-necessary basis. But in moderate to severe psoriasis with a PASI greater than 10, or a DLQI greater than 10 with less severe objective signs, I suggest you refer your patient to a dermatologist for systemic therapy, phototherapy, or a biologic. But patients with severe psoriasis on treatment require monitoring, and we expect shared care with our GPs. A patient with severe psoriasis needs blood pressure and cardiovascular assessment from time to time. A patient who's had a lot of phototherapy is at risk of skin cancer and should be having regular skin checks, particularly if they're fair and have had previous cancers. And patients on systemic agents need blood tests. And we're going to talk about what's required for methotrexate, acitretin, cyclosporin, and biologics. Potential issues with methotrexate are that it's a teratogen and injures spermatozoa, so contraceptive measures are necessary in males and females. In overdose, it causes bone marrow suppression. It can cause acute hepatitis or chronic hepatitis with fibrosis, particularly in patients who already have damaged liver, most often due to previous hepatitis, viral hepatitis, or fatty liver. Pneumonitis is rare. Another problem is methotrexate and folic acid are both yellow tablets, which can confuse the patient. Prior to methotrexate, the dermatologist is going to arrange a number of tests to assess the safety and predict problems on treatment. On methotrexate, regular blood count, liver function and renal function is necessary as a minimum at decreasing intervals, but probably around every 3 months long term, which fits in with a new prescription. From time to time, the dermatologist may refer the patient for a transient elastography scan to ensure that fibrosis is not arising in patients at risk of this. The potential issues with acitretin are that it's a teratogen and is unlikely to be prescribed in a young female of childbearing potential. Mucocutaneous adverse effects are common. Tiredness, myalgia and arthralgia occur in some patients, and hyperlipidemia is a risk. The dermatologist may arrange some screening tests before starting treatment with acitretin and will expect monitoring from time to time with blood count, liver function and lipids. If there is hyperlipidemia, this should be treated, usually with a statin. Now, cyclosporin has other issues because it's also an immune suppressant, as well as treating the psoriasis. This means it can cause infections and skin cancer. It also causes hypertension and renal impairment, besides a list of side effects that are less severe, but may be bothersome to the patient. We particularly want to know the renal function and blood pressure, but also we're going to check the hepatitis serology, HIV serology, and whether there's any risk of tuberculosis in a patient on treatment. On cyclosporin, blood count and creatinine need to be particularly carefully evaluated, as well as blood pressure. From time to time, we'll be reviewing the incidence of tuberculosis and other infections. If hypertension occurs on cyclosporin, this may require a reduction in dose of the drug or treatment of the hypertension. Immunization status should be considered prior to commencing an immune suppressive such as cyclosporin, and if necessary, please update these prior to commencing treatment. The recommended vaccines include the hepatitis A and B and HPV vaccines, unfunded pneumococcus and annual influenza vaccination. Note, live vaccinations are contraindicated on treatment. So don't forget, your patient on cyclosporin is at increased risk of infection. This may require a lower threshold than usual for prescribing antibiotics. It also increases the risk of skin cancer, so encourage sun protection and ensure regular skin checks are undertaken. So if your patient has failed cyclosporin, acitretin, methotrexate and phototherapy, or they've proved unsuitable, we may consider a biologic in a patient with severe psoriasis whose on-treatment PASI score is greater than 15. Biologics are contraindicated if there's current severe infection, such as untreated tuberculosis or hepatitis, moderate to severe heart failure, multiple sclerosis or optic neuritis, and recent malignancy. Prior to starting treatment with biologic, the dermatologist will arrange similar treatment tests to those done prior to cyclosporin. And the immunisations, again, need to be reviewed. On biologics, tests are less frequently required than on the other medicines, but it's general to request a blood count and liver function every 6 months, as well as checking weight. Remember, some of our patients on biologics are also taking acitretin or methotrexate. Biologics also increase the risk of infection, so examine your patient carefully and treat them appropriately. Biologics may increase the risk of heart failure, particularly the TNF-alpha blockers, so at-risk patients require monitoring for cardiovascular disease. If you need any more information, please refer to guidelines on dermnetnz.org. Thank you for listening.